hopefully I'm going to get the right mover on here. For those of you who tweet, my Twitter handle is @ElisBeech, and there's a hashtag ToDipOrNotToDip that's in wide use, so do use it. Yes, great. So before I talk about ToDipOrNotToDip in detail about our quality improvement programme that originated in NHS Bath and North East Somerset about 5 years ago, it's not a quick fix story, I'm going to just place it in the wider context from a national patient safety point of view. We have a UK ambition to reduce antimicrobial resistance. I'm sure you're all very aware of that, and the media have done a brilliant job of promoting this over the last few years. But this is because we need to be able to continue to provide safe and effective care. So we have the government's response to the Jim O'Neill AMR review back in 2016, which was to publish two key ambitions: to reduce inappropriate antibiotic prescribing by 50% by 2020, but I've taken that off, you'll note, and to reduce healthcare-associated gram-negative bloodstream infections by 50%. And the reason I've taken off those deadlines is 2 weeks ago, Matt Hancock's launched, along with Michael Gove, our new UK AMR strategy at Davos, tackling antimicrobial resistance, the next 5-year national action plan, and you can see the 9 ambitions associated with that there, and that includes providing safe and effective care to patients, which is what we're talking about today, but to minimise infection and also to demonstrate appropriate use of antimicrobials. So ToDipOrNotToDip fits really well within this context. And the reason we're worried particularly about gram-negative bloodstream infections is that our E. coli bacteremia rates have continued to increase year on year. I'm sure many of you are aware of this. We have been working over the last year and a half to try and take a whole health economy approach to reduce E. coli bacteremia cases, and this is not working very well at the moment, I would say, looking at the latest data, and this is proving really tricky. It's a sticky, tricky problem. But 75% of these E. coli bacteremias are thought to have a community onset, and about half of those are thought to be associated with a urinary origin. And the risk is greatest among the frail and very elderly. And part of this is associated with how we manage urinary tract infections, and the fact we do have high levels of E. coli resistance to trimethoprim, which has been historically our antibiotic of choice to treat urinary tract infections in primary care. So there's something around we need to change what we're doing and how we're treating urinary tract infections in primary care. So if we look at our antibiotic prescribing, in 2017-18, there were about 33 million antibiotic prescription items. Now, that's lower than the year before, and if we look at the latest 12 months data, that will be lower again, because we do have a lot of success at reducing inappropriate antibiotic use within primary care. And CCGs are doing a brilliant job stepping up to the quality of premium challenge to reduce to fixed national targets. But it's interesting to see that 21% of these antibiotics were actually associated with antibiotics used to treat lower UTI. That's a lot of antibiotic use around lower UTI. And that within these 7 million items prescribed for lower UTI, nearly half of them are used to treat infections in older people. So we've got a lot of prescribing of antibiotics for lower urinary tract infection, and a lot of this is happening in older people, and we know that these are the patient group who are more at risk of those E. coli bloodstream infections. And when you look at what we're using, it's primarily nitrofurantoin and trimethoprim. And we've had a quality premium that has driven a huge shift in our empirical drug of choice. We now have 2/3 of UTIs are now treated with nitrofurantoin rather than 2/3 being treated with trimethoprim. And we changed that around very quickly in about 9 months last year, which was excellent. But we also have a target to reduce empirical use of trimethoprim in people over the age of 70. And again, we've taken out about 40% of antibiotic use in people over the age of 70, trimethoprim use in that age band, which is excellent. But you can see here we still have a lot of trimethoprim use in older people. So we've got 2 issues. We've got a lot of antibiotics being used to treat UTI in older, at-risk, frail people. And we have what is the most appropriate antibiotic to use in those people to treat that UTI. So, talking about long-term care facilities, which is where ToDipOrNotToDip is placed, we have the best data we have had until very recently has come from Australia, where they have into their 2nd year of a point prevalence survey in some long-term care facilities, looking at what how antibiotics are used, and about 10% of residents were prescribed at least one antimicrobial on the single day that this point prevalence survey was carried out, and the top volume were to treat urinary tract infection. So that's quite a lot of antibiotic use in those residents. We have, from CQC, we have about 16,000 care homes providing care for nearly 500,000 people. And we also know that rates of avoidable emergency admissions for older people, avoidable emergency admissions, have been going up, and within this there are infections. So these are things we can do something about to prevent. And I'm really pleased that we have now, for the first time, just published a collaborative publication working with Boots, who service a lot of long-term care facilities across the 4 nations. We've been able to look at exactly what is happening with antibiotic prescribing in residents in these care home settings. So they've taken a year's worth of their dispensing data, and we've analysed that. And you can see this is 500,000 antibiotic prescription items were dispensed for 341,000 residents over that 12-month period. And that 1 in 2 had at least one antibiotic in that 12-month period, and that 40% of these were for treatment for lower UTI, as you can see there. And what this bar chart also shows is whether these were for 1 to 3 days, 4 to 5 days, 6 to 7 days. So it starts to give us some idea of both the treatment of acute UTI, but also the use of antibiotics for prevention, for prophylaxis for UTI. And there's some real concerns about driving the development of resistant E. coli in those situations. So zoning right down to ToDip or not to dip, this is a quality improvement programme. This started in Bath and North East Somerset, as I said, about 5 years ago. It's a patient-centred approach to try and improve the management of urinary tract infection in the care home environment. It was evidence-based, it's very systematic, it applies to all of our nursing homes, and it has been actually running continually since we initiated it because it has been very successful. We had an architecture in place with GPs aligned to the nursing homes through an enhanced service. So on top of that, we had an existing care home pharmacy service funded by the CCG. So we were in a place to do some improvement work systematically. And we had some small funding to have a look and see whether we could do an improvement initially. I should point out that because of the improvement that I'll come on to talk about, this is now day job as normal for those care home pharmacists. But the reason we did it was because local audit, well, national data showed that we had some of the highest broad spectrum prescribing in primary care in the country, which was not good. And when we went to find out why and what was going on, we found a lot of this was happening in care home settings, and a lot of this was happening in patients with dementia and end-of-life care who were really not down for much else. But if they became distressed, then there was a very strong push, quite often from the family's relatives, to do something, and it seemed easiest to use a dipstick, find it was positive and give them some antibiotics for a UTI. And this was the problem. We were finding that we were actually prescribing antibiotics for a positive dipstick, not for a patient with a clinical infection. And guidelines really do not support that approach, although, to be fair, the guidelines were not massively clear at the time. So that's what we set out to change, and that's why it's got the catchy title. So the aim of the project was to implement an educational, a whole quality improvement bundle, which was very much focused around educating those care home staff, but also educating the GPs, and as it turned out, educating the out-of-hours service and the lab. There were lots of cans of worms, as I am sure you can imagine. But within that, we educated around the big picture about why resistance matters and how you should be managing the diagnosis and the subsequent management of those UTIs. We encouraged them to stop using dipsticks, and instead we gave them a clinical assessment form. So we had consistent clinical assessment of the patient that could be faxed through to that aligned GP practice, so they had some clinical information on which to make a treatment decision. And the GPs were strongly encouraged to use that form and to follow the local guidelines. And also something around how do you capture your urine samples and how do you capture them in a usable way. So very much a push to better urine capture. This is an example of a clinical assessment form. You can see that the language used is as plain English as we can get, because we really need the nursing home staff to be able to understand this, and it's very algorithmic. Initially, we piloted this in 8 homes, And I put in here the infographic from the AMR National Action Plan, as I mentioned at the beginning, because this has gone into the action plan as an example of good practice. But what we found in our 8 homes was we found that we were able to reduce the proportion of residents who had an antibiotic for an acute UTI from 1 in 2 residents in our 6-month pre-implementation data analysis to 1 in 4 residents. So we effectively halved the number of residents who were having an antibiotic for an acute UTI. We actually reduced the number of antibiotics given to those residents by 67%. And we took out most of the prophylaxis. So you can see here, 28 residents on antibiotic prophylaxis, got that down to 5. Only 1 resident had to be restarted on prophylaxis. Very concerned about unintended harm. We were looking at admissions data and were very surprised to find that we reduced admissions for UTI, urosepsis and AKI. We did include very strong hydration messages within that educational bundle. So this was then rolled out across all of our nursing homes, and we have continued to do run charts ever since. Because it is a quality improvement, continual improvement. There are lots and lots of areas where we need to improve. But what we've been able to identify now is that we are running at about 12% of our nursing home population are likely to have 1 or more antibiotics to treat acute UTI. This is the what does good look. This is the after bit. So that gives you some idea of burden of UTI in nursing homes. And you can see the seasonal variation of that. And we've been able to reduce the number of antibiotics even further used to treat those acute UTIs. So some patients were having 5 separate acute courses of antibiotics in a 3-month period for their UTI. We also were looking at catheter-associated UTIs, so high risk. And we realised very quickly that we couldn't really improve very well without understanding what our catheter use was like. So we also started to capture information about the number of residents using any form of catheter product in our nursing homes. We think this is the first evidence in England about what is the burden of catheter use in nursing homes. We've got some data for hospital patients, but not for nursing home patients. And you can see there that's running at a steady about 10% of the nursing home resident population have at some point in that 3-month period some form of urinary catheter in use. And you can see what the catheter-associated UTIs look like on top of that, the number of people. And really, really pleased that we've been able to get a reduction in that. You can see back in July, September 2016, really quite a high spike in the number of catheter-associated UTIs, but also the number of antibiotics used to treat those counties. We went back in before the July-September 2017, the quarter before we went back in, we re-educated all of the nursing home staff. We pulled in some of the new resources from the AKI Think Kidneys resources, excellent website. And we don't know, it's very hard to always know what has caused your improvement in detail, but we think re-educating and particularly enforcing the messages about hydration have probably helped. We have shared this widely. There's been a lot of interest. And I'm a strong believer in bottom-up clinical-led improvement, but sharing it because somebody always does it better, and then you get that improvement come back. And one of the places that took this up very early on was Nottingham, who were a vanguard site for care homes, and they had a microbiologist on an HE clinical fellowship for a year, and they had money. And Annie Joseph, who's a microbiologist involved, did a brilliant job of producing some fantastic resources for use. And they implemented this across 5 different CCGs in various different models of implementation. And really interestingly, came up with the same sort of improvement metrics. Well, they used the same metrics, but came up with the same sort of outcomes. So that's brilliant. We have now got people trying to implement this wherever older people are presenting with UTI throughout health and social care settings. So it's moved out of a care home setting situation into ED, for example, and into older persons wards. But Twitter is a really, really, really good way of having lots of very interesting discussions. But this was getting very out of control with a lot of people being very interested, and my NHS Net account couldn't cope, and I really don't know all the answers. So I set up a community of interest using Slack, and if Matt Hancock were here, he'd be very pleased to hear about use of digital apps and all of that to spread innovation. And that's been really, really successful, and I would encourage you to consider that if you're doing an improvement work where people can network, share, you can upload resources, and you can take your problems and somebody's probably got a solution, or they can certainly go and have a look and ask. So these are some of the resources that came out of Nottingham that have gone back into that Slack app resource and are available to share. And in fact, HEE and have now posted these on the HEE site as well. So if you're a health or social care professional, you're working in any of those environments and you're interested in this area, then you're welcome to join. Please email me. There's my email address, and I'll send you an invite to join. So what next? Well, as a result of all this interest, we've been able to review the diagnostic guidance for UTI that PHE own. And we have new diagnostic guidance for the first time for people over the age of 65, which is brilliant. And it starts with do not use urine dipsticks because they are likely to have asymptomatic bacteria that will give you a positive nitrite result. So it doesn't add to your clinical assessment of that patient. And it is likely that you will jump to a conclusion they have a UTI and you will miss probably what is wrong with them. What I should have said back in Bath and North East Somerset, we reduced a lot of unnecessary antibiotic use in our patient group, but we also improved appropriate antibiotic use. And one of the things we found was that pyelonephritis, or upper UTI, or ascending UTI, was probably not being treated appropriately in some patients because of that positive dipstick. It missed the clinical symptoms. And we found that we had improved management of upper UTI in that patient group, and we think that contributed to some of those reduced admissions. We have new nice guidance for UTI ×4 plus prostatitis that have come out on the NICE website. So go and have a look, and there's a really good opportunity. We've got good diagnostic guidance now, we've got new treatment guidance, and ToDipOrNotToDip is being developed into an improvement toolkit by NHS Improvement, with the view to then offering that back to the system as a way of sharing models of implementation in different care settings. So if anybody has done some improvement work with ToDipOrNotToDip model, would you let me know so we can include that in the toolkit. We have a new national action plan with those 2 key ambitions, and NHS England's AMR Diagnostic Collaborative have made this a priority work stream to improve the management of UTI. The NHS sequence for next year, we are hoping, will be including a focus on improving lower UTI management, diagnosis and management in older people in all acute providers wherever they present. And the long-term plan provides many opportunities to implement improvement in the way we manage UTI for older people wherever they're cared for across those community networks. And NHS England's Medicines Optimisation Care Homes programme is going to be adopting and importing ToDipOrNotToDip within the pharmacy medicines optimisation care pathways that they deliver. So this is a really good example of a bottom-up clinical-led approach that's done very rapid spread and adoption, not using a top-down model, but is now being picked up by the top and will come back down again. Sorry, time to finish. So just to finish, there's my contact details. If you're interested, please get in touch.